welcome to Word Call Wednesday. I am going to try to break down all of the most common pages you'll get as an intern and junior doctor, because I know sometimes it's really hard to figure out when you're getting page after page after page what kind of requires your urgent assessment and review and what can be pushed back for 30 to 40 minutes. So today we're going to talk about blood pressure because it is one of the most common things that you will get paged about. Every single shift you will get a page about blood pressure. Patients in the hospital occupy both ends of the spectrum, being too hypertensive and hypotensive. And because nurses are obligated to inform you when vitals are outside of a derangement that they're comfortable with, you will get paged about blood pressure. So we're going to start with hypertension and talk about what you should be thinking about in your mind when you're triaging your pages, or what to kind of go through in your mind as you're on your way to review a patient to make a management plan. So to start, there's three main classifications of hypertension, and it really determines how you're going to treat it in hospital. Group 1 is hypertension over 180, 110, and this is a group without symptoms. So no headache, no dizziness, no visual changes. And this group really, you have days to manage blood pressure, and in hospital there are a laundry list of items that are going to cause hypertension. They could have been unwell when they first got admitted and we withheld all of their medications. Now they're getting better and their regular hypertension is returning. They could be in pain. One of the most common reasons people are hypertensive in hospital could be constipated, retaining urine. We could have given them 4 liters of fluid in the last 24 hours. So there's lots of things to think about, why somebody would be hypertensive, including stress and anxiety about why they're there, what's happening to them. Do they just need to vent a little bit to calm themselves down? So that first group, without symptoms, you really have time, and serial measurements are paramount. Never do anything off an isolated vital. Make sure that you get a few BP measures, 30 minutes, 45 minutes apart, and just see if you can intervene without pharmacological therapy, because oftentimes this group doesn't need it. Group 2 is hypertensive urgency, and their blood pressure is over 180, 110, but with symptoms. So they might have headache, dizziness, visual changes, things that, you're starting to be concerned about, but you still have time to play with. So this group, if they do need blood pressure reducing, can be done within the time frame of hours. Again, same list of going through, trying to figure out why they're hypertensive. Are they pain? Do they have any of the things I just talked about? Is there anything that you can address before giving pharmacological therapy? Now, the difference between this group and the hypertensive emergency are essentially signs of the end organ damage. So in this group, you're really going to need to examine the patient and make sure that you don't have a worst case scenario on your hands before you decide to just treat them with some sort of oral medication. Now, the last group, which is the hypertensive emergency group, are hypertension 220 over 140 with symptoms and with signs of end organ damage. So these are your emergencies. So could be associated with an aortic dissection, an acute MI, acute pulmonary edema, intracerebral hemorrhages, eclampsia of pregnancy. What else? You could have a pheochromocytoma, just the weird, rare, and wonderful that you don't see that often on the wards, but you need to have in the back of your mind to be able to take a history, examine the patient, and make sure that they don't exhibit anything that's concerning for these life-threatening syndromes. If none of those things are present and they're just the hypertensive with symptoms, group 2, you usually can treat them with like an oral amlodipine. Always refer to your local guidelines. Each unit or department, state, wherever you work, will have their own protocols for managing each class and what they recommend for their country. In the last group, the emergency group, it is an emergency, so urgent escalation to your seniors, making sure you're going through a proper doctor's ABCD. Usually they get sent to HDU or ICU situation where they can have an ART line and blood pressure monitoring, and these need to be treated generally within minutes. So they get IV hydralazine, labetalol, something that acts quickly but needs to be monitored. Now, just a caution with, all of the groups, generally speaking, we don't want to drop the blood pressure by more than about 25% in a couple hours. It carries a stroke risk. So like I said, especially with group 1 and 2, you have time. Don't panic. Just make sure that you're not missing something serious, and give them time to just settle on the wards. Now, with the hypotensive group, again, most patients are unwell. They're infected, septic, they've had surgery, they've been fasted for a long time. We have given them too many medications potentially. There's lots of reasons to be on the opposite end of the spectrum and be hypotensive as well. Again, serial measures are important, and making sure the patient, or not making sure, but figuring out if the patient is symptomatic or not is very important, because if somebody, a little lady that weighs 40 kilograms has a blood pressure of 89 and it alerts nursing staff and medical officers that, hey, this blood pressure is deranged, it might be perfectly normal for her. So it's important to look at trends, make sure that you're taking serial measures, and if it is a true hypotension or they're symptomatic, that's when you can start thinking about treatment. Generally, first line always is I just ask people to drink orally if they can, because a lot of the times people are in hospital, they're unwell, they're not eating and drinking as normally, and they might be intravascularly depleted. So that's usually step 1, is just asking them to drink. And if they have been unwell and they've got renal impairment, or they have been septic and we've given them all sorts of medications, sometimes it's important to make sure that we've withheld the appropriate medications, that they're not still on the regular antihypertensives, regular diuretics, things that are dropping their blood pressure when they already have a reduced blood pressure from being unwell. So just some things to think about with the low group. If they do need fluids, it's not a problem to get access and give IV fluids. However, it is so important to clarify how long you want the fluids to go, how much fluids you want for that particular body weight, or ejection fraction if they've got cardiac failure, renal disease. Sometimes fluids get charted and then they just keep going and going and going, and there's not a self-regulation or a check to really interrogate why they've been put on fluids. If you're putting them on fluids, always a good idea to hand over to the home team to, hey, do a fluid balance assessment when you see them on rounds the next day. See what's appropriate for your patients, because we don't want to iatrogenically be overloading them and causing more problems than we were originally trying to solve. So that is just a little bit about both ends of the spectrum, high and low blood pressure. Obviously, I'm sure there's lots of things that I forgot, but that is generally how I would think about patients on the wards when you get paged, and the main things that you want to rule out. If you have any questions, drop them below. Bye.